Hey guys, so today we're going to start with sepsis management and talk a little bit about what is sepsis and what are some of the signs and symptoms that we might see, some of the clinical indications, some of the treatment modalities. So we're going to go ahead and get started. So defining sepsis. Sepsis is essentially an extreme reaction that the body's having to an infection, right? It can range from the infection itself and bacteremia, which is an infection with bacteria in the bloodstream, to sepsis, then to septic shock, and then can eventually lead to multi-organ dysfunction syndrome and death. So there's a really big spectrum out there. There used to be a category where it was, you could have a patient with Sears criteria and then sepsis plus Sears and then septic shock. And they've kind of changed some of the definitions a little bit, which has made it a little confusing, I think, for some practitioners because we look at this as a black and white definition, but sepsis really isn't black and white. It's very vague. It can be very difficult to recognize. It can be challenging to treat. And so just keep that in mind as we go through all of this information, that it is a continuum and that it's not black and white. It does flow pretty freely. So pathophysiology, what do we see? So there is a immune and inflammatory response when somebody has a septic infection, okay, they're in septic shock. That immune and inflammatory response causes vasodilation. That's going to reduce your venous return, right? So if you have vasodilation, you've got a relaxation of those blood vessels. A relaxation of blood vessels decreases the amount of blood that can return to the central core. And it decreases your cardiac output because, again, you've got less blood returning because those vessels are now nice and big and wide. So that blood that was flowing through it, when the vessels widen, kind of slows down a little bit more because there's not that pressure to keep it moving forward. Whereas when they're nice and tight, it's more pressure. It's like with a fire hose versus a garden hose. When you turn it on, just a little bit of pressure. It doesn't really do too much, but then whoo, you can get that going. So when you have that response happen, it can lead to poor tissue perfusion, right? You've got less blood flowing to the vital areas. Those vital areas need oxygen. Blood delivers oxygen. We've got poor tissue perfusion now, and then leading to tissue death. So this diagram that we have here shows some of the various problems that sepsis can cause in the body. So you can see there's kind of 4 major categories, but again, there is so much involved in this process. You could spend your entire career just focused on this. But here are some of the basic things that can happen. So your endothelial dysfunction, so that's those vessels are starting to not function appropriately. That causes capillary leakage, okay? So now you've got fluid that was in your vasculature is now starting to leak out. That's causing third spacing. We'll talk about that later, but that's when you have those really puffy patients in the ICU. Coagulopathies can occur. Cellular dysfunction, right? Because again, blood flow is not getting to areas that it needs to, so those tissues aren't getting perfused with oxygen, and so now they're starting to have cellular dysfunction. And then cardiovascular dysfunction, we talked about hypotension, vasodilation, and all of those things can lead to multi-organ failure, and that's where we're eventually going to talk about on the spectrum as we get a little bit further. But just getting started, initial infection / early sepsis. So it's kind of hard to define this, but infection is defined as the invasion of normally sterile tissues by organisms resulting in infectious pathology. So what does that actually mean? Bugs are where there shouldn't be bugs, okay? Causing a response from our immune system. Bacteremia is the presence of bacteria in the blood. Infectious and bacteremia can both progress to sepsis, but not every infection and every bacteremic patient will become septic, okay? So they all have the potential, but they're not all going to get to that stage. And because of that, there's no formal definition of what early sepsis means. So you just have to consider, because there's a lack of a definition, monitoring patients that are suspected of potentially developing sepsis in order to prevent sepsis. And we're going to talk a little bit later about what high risk factors are for patients developing sepsis and some of the other signs and symptoms that we can see as they escalate. But to get started initially, it's really focused on the infection. And again, not every person's going to advance to sepsis, but some of them are. And so, this slide talks about watch for the time, right? So you have a high or low temp, you have an actual infectious source, a mental decline, they look and appear extremely ill. So this was something that was put out by the Sepsis Alliance to try and capture these patients, because what happens is a lot of these patients don't get recognized early enough on, and we see it all the time, right? We'll have say an elderly patient coming in from a local nursing home. Okay, they have a baseline of dementia, so they already are mildly confused. You don't know the patient as well as, say, the nursing facility does. So you might not think that this is a decline from their normal mental status when it is. You might see that they don't have an elevated temp. Maybe they have a slightly lower temp. People kind of forget that lower temps can be a sign of sepsis as well. We might not recognize an area for infection because we can't do a great exam or assessment because they're not able to answer questions for us. So we're only able to go off of physical exam without being able to get any feedback from the patient. So that can make it challenging, say, if they have a UTI. We don't recognize it for a couple of hours because they haven't voided. And then when they haven't voided, and then we end up doing a straight cath or send off a urine sample and then discover it then, they weren't able to tell us that they were having issues for the last couple of days. So it's all about just trying to capture as many people as we can that could potentially become septic so that we can treat them early, manage them safely, and then keep them from developing these worsening symptoms that we're going to see later. Okay, so sepsis itself. Sepsis is a life-threatening organ dysfunction, and it's caused by a dysregulated host response to an infection. So this means that our body's not only battling the infection, right, but it's mounting this overwhelming response. And that overwhelming response starts to cause damage to our other organs and tissues, which leads to organ dysfunction. So our body overdoes it and then essentially starts to hurt itself. So, when you've got organ dysfunction, when you've got an increase in several indicators that show that we have organ dysfunction, and we're going to talk about that later with the SOFA and the Q-SOFA score. So just keep that in mind. But this picture gives you a little bit of symptoms that various patients can have if they have sepsis. Now, you can see here, looking at this slide, so shiver, fever, very cold, extreme pain or general discomfort, pale, discolored skin, difficult to arouse, I feel like I might die, short of breath. These are all somewhat vague symptoms that we can actually see in a lot of other diagnoses, not just sepsis. So that's why sepsis is so challenging to see. And some of these things we actually need patients to be able to tell us. And like we used in the example before from the woman with the nursing home, they can't. So we really just want to keep an open mind. If we have a patient, could they have an infection? And if they potentially have an infection, do they develop any of these symptoms that are telling us that the infection has gone from a normal infection with a normal response to this overwhelming response that's going to start causing problems for the rest of their body. And then eventually, if they are in that overwhelming response, it's going to lead to septic shock. So septic shock is essentially when you've got sepsis, but then you also have a vasodilatory effect with it as well. So it's a type of vasodilatory or a distributive shock. So the extreme inflammatory response causes that vasodilation. So the relaxing of the blood vessels, so where they're normally kind of nice and tight, you got your pressure 120/60. Well, now they're relaxed, and now they're getting to be, 70/40, and they're just kind of floppy. They're relaxed. They're not tightening and squeezing the way that you would expect a normal person to do if their perfusion was low. All right, so that vasodilation in turn causes hypotension and decreased cardiac output, right? So the endothelial cells, they start to leak fluid. We talked about that a little bit earlier, the third spacing. So it's leaking fluid from inside the vasculature into the surrounding tissue. That's when you've got the severe pitting edema in the ICU. You'll hear some nurses refer to it as the Michelin Man because their patients are extremely swollen throughout their entire body. And that's because of that third spacing. The fluids that you're giving them is no longer staying inside the blood vessels. It's starting to just kind of leak out. Cells have to start using anaerobic respiration because there's low available oxygen. So you remember aerobic respiration is normal, right? You get oxygen, you use that, you make energy, then energy goes out. Well, now, because of that low blood flow, the hypotension, the decreased cardiac output, cells aren't getting the oxygen that they need. Oxygen's carried in blood. That blood's not getting to where it needs to go, so the cells aren't getting what they need. So now they use aerobic, anaerobic respiration, and that's without oxygen, right? Or with less oxygen. So that's worsening the acidosis and creates lactic acid as a byproduct, okay? And that's why we see lactates elevate in these patients. We're going to talk more about lactate later. A patient that's in true septic shock is going to have a circulatory, a cellular, or a metabolic abnormality that is caused by an infection. And patients that reach this level have a greater risk of mortality than just sepsis alone. So again, sepsis is an overwhelming response, but septic shock is when that overwhelming response now starts to cause cardiac, cellular, or metabolic abnormalities. So we've gotten past the body's ability to compensate and cope with this. Sepsis, they can still partially compensate. Septic shock, they're starting to not be able to compensate. So these patients are going to require vasopressors, even though we've given them adequate fluid resuscitation to maintain an appropriate blood pressure. It's not going to be enough. They're going to need vasopressors to keep up that organ perfusion. We want the blood to be able to get around to all those core organs, right? And all that tissue. And they'll routinely have the elevated lactate, which again, we're going to talk about a little bit later. So all of this so far, not great, right? You started with an infection. Okay, body kind of responds appropriately. Then we move to sepsis. All right, well, body's starting to overreact, but it's still able to compensate for itself and keep itself somewhat in line. Now in septic shock, it's still overreacting, and now it's starting to cause more problems. Sorry about that. And then we have finally culminating to multi-organ dysfunction syndrome, or MODS. Okay, so what is this? It's a progressively worsening organ dysfunction in an acutely ill patient. So their body is not able to maintain homeostasis anymore without interventions from us to help to support them. So that means we might support their heart through vasopressors or inotropes, so medications. Their lungs through a ventilator. So they may be intubated and on a ventilator. Now we're controlling their respiratory rate and their volumes and their minute ventilation. Their kidneys, we might be supporting with dialysis, and then other organs through medications and careful lab monitoring. So when the body reaches this stage, it's starting to shut down, okay? Everything is starting to not work, and that's why we now have to try and work. This is the severe end of the illness, all right? This is what we reach if we haven't recognized it. Maybe we weren't able to treat it quickly enough. Maybe we had a patient that, what's happening a lot with COVID is people are afraid to come into the hospital because they're afraid to get sick. And so, maybe they stayed home for a while thinking this will be okay, things will get better. And sometimes it just progresses this way. And depending on what other comorbidities the patient may have, it just continues to move this way. So there are some other causes that can cause this, that can cause MODS. So it's not just septic shock, okay? There are other non-infectious conditions that can cause this, but in general, the greater the number of organ failures, the higher the mortality of the patient, right? And there's a couple of organ-specific parameters that we can use to diagnose this. So one of them, we look at our respiratory system, right? We talked about how we might have to help support the respiratory system. So one thing we can think of when we're starting to try to determine if a patient has reached the stage is something called a PF ratio. So that's your PaO2 divided by your FiO2. And that starts to decrease in these patients. So what that means is that even though your FiO2 is starting to escalate and that number is really high, your PaO2 isn't escalating, it's actually starting to fall. Okay, so that ratio gets a little bit tighter and that overall number starts to fall. And that's telling us that even though we're pushing all of this oxygen into that body, tissues aren't getting it. It's not getting to where it needs to go. Hematologically, we might see platelet count decreasing. We could see our bilirubin elevating. So that tells us that our liver is starting to have some challenges. Our creatinine will increase, or our urine output will decrease or be absent. That's telling us our kidneys are starting to have problems. Our GCS can worsen, so our brain is poorly perfused. And then again, hypotensive, requiring vasopressors. We saw that in septic shock as well. And that was kind of the beginning key is telling us that we were in septic shock. So as we escalate through, things continue to get worse. So how do we recognize it? If the symptoms are kind of vague, there's not really great clear definitions between each stage. There are definitely some key factors, but it can be a little bit challenging. So how do we figure out who has it? So Sears criteria, it used to be used to identify people that had the potential for sepsis, but it's really fallen out of favor because it's considered by a lot of experts to be a not so precise way of catching these patients. So while we do kind of want to cast this wide net and ensure that we treat as many patients with an infection that are advancing to sepsis as we can, because we don't want those patients to fall through the cracks, Sears criteria was found to be a little too global, right? So it was, if you met 2 or more of these criteria, then you met Sears criteria and you could be flagged for potential sepsis. But you can see that it's fairly vague, right? Like, you know, temperature high or low, heart rate, respiratory rate, the white blood cell count we can't get pre-hospitally or immediately in the ED, right? So it kind of pushes us away from being able to give a very quick response to, do they meet SEERS criteria, yes or no? And you can be positive on a lot of these from very other things, right? Like, you could have heat stroke and have an elevated temp, elevated heart rate, and elevated respiratory rate and not meet this criteria, right? So it's not something that's used often or recommended, I should say, often by experts anymore, but I think it is still used somewhat because this was something that was one of the main criteria points that was used for a long time. For SEERS itself is a form of dysregulated inflammation, okay? So previously, again, it was defined as abnormalities in 2 or more of these things, but because it can be related to things that are non-infectious, like autoimmune disorders, pancreatitis, thromboembolisms, burns, surgery, those are some other things that could cause you to come positive on SEERS criteria. We tend to just not use it anymore. So what we do recommend, though, is this next one, the QSOFA criteria, okay? So QSOFA tool is a modified tool to assess patients outside of the ICU as a way to quickly and easily identify somebody that could be septic or develop. So it's a modification of the SOFA tool, which we'll talk about next, which is why it's referred to as the quick SOFA or the QSOFA. So it's greater than 2 or more of these criteria points is associated with a poor outcome. And it's nice and easy to calculate because it only has 3 components. All of them are readily identifiable at the bedside. You don't need to wait for any labs. You don't have to get any further information. You can do all of this pre-hospitally, in the ED, out at home, in the car, wherever you are. So it includes the respiratory rate of greater than 22, altered mentation, so any GCS of less than 15, and a systolic pressure of less than 100. All right, so if you have 2 or more of those factors, and you have a potential for infection, then that needs to clue you in that this needs to be a sepsis alert or a patient that I'm going to use my sepsis protocols for. Now, just because this is a positive QSOFA criteria, so say you have a patient that meets this criteria, doesn't definitively diagnose sepsis. It just helps to identify patients that are at a risk of dying from their infection. So it's not your definitive diagnosis, but because like we said earlier, we want to capture as many patients as we can within reason and appropriately to ensure that we treat them as quickly as not as quickly, but as early as possible in their disease process to prevent them from becoming septic shock and MODS. We just want to make sure that we start their treatment. And that's when what the QSOFA criteria helps us to do is start that initial treatment until we can actually come up with our definitive diagnosis. And if it ends up not being sepsis, that's okay, right? But if it does end up being sepsis, now we're already ahead of the game. All right, and then the SOFA criteria. So the SOFA score is usually used in the ICU because it has a lot more components that require frequent monitoring and lab work. So it's made up of the 6 components that you can see here on this screen. So you've got your PF ratio that we talked about before, right? Hypotension or vasopressors are on board. Decreased platelets, which we talked about a little bit, MODS, remember? Let's see, decreased GCS, decreased bilirubin, increased creatinine. So we talked all about that a little bit in MODS, where you reach the end stages of sepsis, septic shock into MODS, things are starting to fail. And that's where the SOFA criteria comes in, is it's really wanting to assess how bad is this failure, right? So what it does is each of these components has a range of points from 0 to 4. So the actual scale is much more involved than this picture, but this picture is a phenomenal way of being able to look at it. They did it at the JAMA network, and it just kind of breaks it down nicely into what the criteria are. But each of these components are worth between 0 and 4 points. So the more points that the patient scores, the worse their potential outcome is. So it just kind of helps to give us a really good picture as to what's going on, and it helps to quantify all of the things that you were seeing before. So while you might have, yeah, I can see that there's kidney dysfunction, liver dysfunction, and neurodysfunction, this puts it into the ability to be able to quantify it and actually give a number to it. And so it can just help with our trending, our tracking, and our initial assessment of these patients. So what are some signs and symptoms that we can actually see? So usually somebody is suspected of sepsis. They typically have hypotension, tachycardia, fever, an elevated white blood cell count, which is also known as leukocytosis. And as the severity worsens, the patient develops signs of shock. So you can see cool skin, cyanosis, organ dysfunctions will start to develop, such as a decrease in urine output, right? Decreased blood flow to the kidneys, altered mental status, decreased blood flow to the brain. The challenge is that the symptoms are vague and the patient's presentation can be nonspecific. So there are other conditions that can mimic some of these symptoms, like pancreatitis. So it can really make it challenging to diagnose a patient with sepsis on symptoms alone. And, signs and symptoms, while they aren't super specific, they can also include hypotension, which we've talked about, an elevated or a low temperature, elevated heart rate, elevated respiratory rate. So those are some vital sign changes that you can start to see, and they may even be slight, but it's something that'll kind of clue you in that there could be something more going on. They could have signs of poor end organ perfusion. So initially, they might have warm, flushed skin that can be present in early phases of sepsis, but as it progresses to shock, the skin becomes cool due to the redirection of blood flow to those poor organs, right? So you've got decreased cap refill. You can see cyanosis. You can see mottling. Mottling is always an indication of shock. Additional signs of poor perfusion can include altered mental status, restlessness, lethargy from the decreased blood flow to the brain, decreased absent urine output, decreased blood flow to the kidneys. So those are things that we want to keep track of. And ileus or absent bowel sounds can be a sign of end stage hypoperfusion for your GI system, because you've got decreased blood flow to the intestines. And that's not something that we usually see right off the bat in our initial assessment. But if they've progressed far enough down this algorithm, then they could. And if it wasn't challenging enough to try to determine if the symptoms are caused by an infection or not, because some of them are kind of vague, the symptoms can also be masked by pre-existing conditions or medications. So, for example, you can have an older patient on a beta blocker, and that's preventing their heart rate from increasing, even while their blood pressure is decreasing. So they may come in and you would expect them to be tachycardic because you think, okay, sepsis, tachycardia, but they might not be because the medication is preventing it. So that's why a full sample history is so important. Helps you put the pieces together with your assessment. You've got your sample history, and then you're able to have a little bit more insight as to what could be going on with this patient. So if you've got a patient that meets at least 2 of the QSOFA criteria in the field or in the ED, and you feel that they have a potential source of infection, treat them as a septic patient, all right? Remember, some of our sickest patients can look okay because they're still compensating. And when those compensatory mechanisms give out and they begin to decompensate, it can happen really rapidly. It can catch us by surprise if we're not expecting it. And so always just try and be prepared and be ahead of it by getting a good history and doing a thorough exam. And that's why that QSOFA criteria is so beneficial, because it helps to key us in that there could be something going on with this patient that's related to sepsis. If they meet 2 or more of those criteria markers plus have a source of infection, we can just go ahead and start treating and start moving in that direction. And then hopefully keep them from progressing into those later stages that we know it shows worse mortality. Okay, so what are some other things besides just our physical assessment? We may, if we're in the ED or in the inpatient unit, have the luxury of having labs, right? I know pre-hospitally, that's usually not a luxury that we have, but in the hospital we do. So labs are also non-specific. This whole thing is kind of non-specific. But there are some labs abnormalities that are more associated with sepsis, or at least tissue hyperperfusion and organ dysfunction. So that's what we're going to focus on. And what sepsis really is just taking all of these vague, non-specific things, putting them together and saying, yes, when they're all together in one bundle, this is sepsis. Individually, it's not enough to diagnose the patient, but together, it is. So we're going to start with white blood cells. So they're a part of the immune system and help fight infection, right? We've got a bunch of different types. And so you can see all of the different types of white blood cells here. So some are involved in recognizing intruders. Some kill harmful bacteria. Others create antibodies to protect the body from future exposure to bacteria and viruses. So there's several different types of white blood cells, which are also called leukocytes. That's what white blood cells are referred to as a whole, or leukocytes. So when labs get drawn, if a CBC is sent to the lab, you're going to get a WBC back, a white blood cell count back, right? So if the patient has what's called leukocytosis, right, that's an elevated white cell count, greater than 1,200 or 12,000, sorry. And if they have leukopenia, which is a low white cell count, that falls below 4,000. So you're like, okay, well, what do I do with that information though? There's all of these different types of white blood cell counts. How do I know? Well, your WBC is giving you an overall number of how many white blood cells, right? But it's not specifying which ones. So you run a CBC with differential. So you'll hear it referred to as a CBC with diff, okay? Which measures the percentage of the various types of white cells present in the blood. So in doing this, you can see which white blood cells are the most prevalent, and it might help you with your diagnosis. So for example, if you saw an increase in eosinophils, right? They're known for their role in allergy symptoms. You might suspect the patient had a recent allergic reaction. If you have an increased neutrophils and lymphocytes, however, you might be more concerned for an infection process. There's a lot of reasons that a white blood cell count can elevate. It's common to elevate after surgery even. So we just really want to figure out what white blood cells are elevated using that percentage on a CBC with diff. And it's just going to give us a little bit more of a clue. Another thing that we can see when we run a CBC are bands. So bands are immature neutrophils. So that type of white blood cell that we talked about in that last slide, right? And neutrophils are something that you would see in a patient that's having an infection. So bands are a cell that get released after injury or inflammation. So it tells you that there's an inflammatory process occurring. But if you've got more than 10% bands in your CBC with diff, it indicates a major infection because those immature blood cells are being sent out too early to fight the infection. So the body's saying, you know what, I've sent everybody out. All of my mature neutrophils are out and they're trying their best, but they're still not succeeding. And I just need to send as many extra people as I can. So even though these cells aren't mature enough to actually be deployed, they're getting sent out. So you'll see somebody and they'll refer to that as a band anemia, but it's an elevated bands. Lactate. This is something that we hear fairly frequently when we talk about sepsis, right? So when oxygen's not readily available, body uses anaerobic metabolism to produce energy. We talked about that in a couple of slides before. Well, the byproduct of using anaerobic metabolism is lactate and hydrogen ions, all right? So in sepsis, since there's this dysfunction in the microcirculation where the oxygen is exchanged, that leads to that increased lactate production because they're using anaerobic metabolism. And lactate's a measure of your tissue perfusion, right? Which makes sense. If your tissues aren't being perfused and they have to use anaerobic metabolism, then you're going to get a byproduct of lactate. So if you've got an elevated lactate, that's telling you your tissues aren't being perfused. So it'll tell you how well your cells are being oxygenated regardless of your blood pressure and regardless really of your SpO2, right? So a high lactate is going to tell us that our cells are struggling because they're not receiving the oxygen that they need to use normal aerobic metabolism. And now they're having to use anaerobic metabolism. So if you've got an elevated lactate of say greater than 2, it might tell us that the organs aren't being perfused at the level that they would like, right? Because they're throwing off some of this byproduct, even if the patient's not hypotensive, okay? And that's why it's really important as a part of your initial evaluation, because an elevated lactate is associated with poor prognosis, and it's something that you can track as you're treating your patient. If you have a serum lactate of greater than 4, that's called lactic acidosis, and it's consistent with septic shock. Again, it's not diagnostic of just septic shock because there's other causes of lactic acidosis besides sepsis. You have other types of shock, cardiac arrest, severe lung disease, trauma, seizures, burns is a big one, DKA, liver dysfunctions. Those can all cause an elevated lactate. But you take that elevated lactate plus your QSOFA criteria, plus your infection source, plus your assessment and your vitals. Like this is how it all comes together. This is why it's so important to get all of the information from all of these sources so you can put it together, because yes, you can say lactate can be caused by a lot of other things, but can it be caused by a lot of other things if all of these other components are there on this one page? And then, you know, blood cultures, right? We're always talking about get blood cultures, get them early. They're really important to draw early. We're going to talk about antibiotics a little bit. You want to make sure you draw it before an antibiotic is ever given so it doesn't skew the results, but it's just going to give us another piece of the puzzle. It's going to tell us if they have any potential infection within their blood, okay? So this is really important to get as early as possible. We want to get 2 sets of blood cultures from 2 different sites. If you put in a brand new IV, you can draw blood cultures off of a brand new IV that hasn't had anything else drawn off of it or pushed into it. If EMS brings a patient in and they put an IV in, you cannot draw blood cultures off of that IV that's already been placed, because it could potentially get contaminated because it's been used, and you want this to be a fresh site so that we don't accidentally contaminate the specimen and think that the patient has a bacteremia when they and we want to use 2 different sites so that, again, we can confirm that it's not, say, just the IV that got contaminated, it's actually the patient. So that's why we do 2 sites. And then here are just some other labs that can help you diagnose sepsis. Again, none of these are individually are enough to confirm the diagnosis, but used in collaboration with the sample history, your assessment, the other findings, this can help to support that. And a lot of this you should recognize from the SOFA criteria that we talked about a little while ago. All right, so where can you potentially see these infectious sites in the body, right? So the 4 big areas is skin, lungs, abdomen, and your urinary tract. The most common places for infections to flourish. These are different types of bacteria. So we've got gram-positive and gram-negative. So bacteria is the main pathogen that causes sepsis. And you can see in the image how different gram-positive and gram-negative bacteria outer layers look. So if you look right in through here, you can see how different these layers are, right? So that's why getting blood cultures as soon as possible is helpful, because it's going to help to identify the type of bacteria so we can choose the appropriate antibiotic to be able to penetrate the outer layers so we treat the patient better fast. Viruses are another pathogen that can cause severe disease, and some viruses that we typically see include flu A, flu B, RSV, and COVID-19. And the incidence of fungal sepsis is definitely less common. It's there, but it's much less common. Bacteria is really your primary cause of sepsis in most situations. So what patients are potentially at risk for this? Can anybody develop sepsis, or are there some people that are at a higher risk? And like everything, of course, there are people that are at a higher risk. And so these aren't all of the risk factors, but they're definitely quite a few of them that can predispose a person to be a higher risk for developing sepsis from a infection. So consider these when you're getting your sample history and getting background information from your patient, because it might be able to clue you in a little bit more as a potential for their infection to develop into sepsis. Anytime somebody's recently been admitted, you can see intensive care unit admission or previous hospitalizations. It's always at a higher risk. If they have known bacteremia, right? That's bacteria in the blood. Bacteria in the blood naturally puts them at a higher risk for sepsis than, say, a localized infection as a UTI. Advanced age is always going to predispose anybody that's immunocompromised, diabetics, patients that are obese, they have a history or current cancer. Para or quadriplegic, because they're able to maybe less move independently on their own to reposition, so they have a higher risk of say, a pneumonia from not being able to clear secretions or cough well, wounds that can become septic. So just keep some of these criteria in mind as you're getting report on your patient. What do we do to initially stabilize and treat these guys? Right? They can be really challenging because they can, on one hand, look okay coming in, and then on another hand, not look so great coming in and be crashing pretty quickly. So how do we best manage this? So let's say we go to a nursing home for an 80-year-old female. She's got a GCS of 13, heart rate's 105, blood pressure is 82/45, respiratory rate's 26, and an SpO2 of 92% on room air. Staff gives you a report, tells you she's been declining for a couple of days, she's got foul-smelling urine. What's going through your mind? She could be septic. Hopefully, that's what's going through your mind. So using the QSOFA criteria, you can see she meets the criteria for all 3, right? Decreased PCS, fast respiratory rate, low blood pressure. Now they're telling you that she's got foul-smelling urine. There's your potential infection. Hey, I'm going to go into the ED and say we might have somebody that's septic. When she arrives to the ED shortly after, she becomes completely unresponsive. All right? She's got snoring respirations, and then your provider turns to you and said, we're going to intubate her. How do we do that safely? Because this isn't somebody that you can just pull, full dose meds, jump right on it. This is somebody that we should prepare. We should prep them. We should boost them up a little bit and make them a little bit more safe to be able to move forward with a procedure like that. So this chart, I think, is a phenomenal chart. Shows how quickly various patients can go from a normal SpO2 to a grossly normal SpO2. And you can see in all of these, there's a pretty quick cutoff, right? Like they're chugging along, and then it's like, all right, I start to fall. Oh, now I'm really falling. And that's how it is for all of these different types of patients. But we're going to go through them. So if you look at this green line, okay, you can see a normal 70-kilo adult can maintain their SpO2 for quite a while. It can be 6 to 8 minutes before they drop below 90%, and then they drop rapidly. Okay, and that is in a very healthy, normal, think physically fit military type of person, okay, not your average Joe. Now, if we look at our red line, moderately ill adult of the same size, so 70 kilos, which 70 kilos, let's be real, is not a very common weight for adults anymore, right? So we're talking about a pretty small, normal sized adult, 70 kilos, moderately ill. You can see that they only have 3 to 4 minutes before they start to do this drop off, okay? So that time is about in half. Still sounds like a lot of time, but when you're doing an intubation attempt, it doesn't feel like that much time. And some of these people aren't even gonna last that long, okay? All right, children is the blue line, obese adults is this black line. So you can see that they can be otherwise healthy, but just meet one of those 2 criterias and their SpO2 drops even faster. So why is this important? And more importantly, how do we prevent our septic patient from falling off that curve quickly? Well, we pre-oxygenate and we apneic oxygenate, all right? So why do we do that? Pre-oxygenation, it fills the lungs with oxygen. So it helps us to achieve our highest SpO2 that we can before our first intubation attempt. And we already know that they're having problems when it comes to their oxygenation because they've got decreased blood flow, right? So their cells are already struggling with getting oxygen. So we want to try to optimize them as much as possible. When we paralyze somebody for intubation, we temporarily stop their respirations until we place the ET tube and start breathing for them again, right? So if there's a prolonged period of that time where they're not breathing at all, there's no oxygen exchange. So we want to make sure that we don't have them fall off that curve really fast, right? Because the really sick patients can fall off that curve really fast. And when I say fast, I mean like 15 to 30 seconds after their last breath, you can see them starting to decompensate and desaturate. So we want to give ourselves as much time as possible before we do that first attempt. And we would achieve this by having both a nasal cannula and a non-rebreather. You could also do a nasal cannula and BiPAP if they were already on BiPAP and they were maintaining appropriately enough to be on BiPAP. Both can be turned up to 25 liters a minute, nasal cannula and non-rebreather, for the purpose of pre-oxygenation, and should be put on as early as possible. So ideally, you want to have this on for 3 to 5 minutes before your first intubation attempt to really make sure you wash out those lungs and fill them with a lot of oxygen. So that's kind of talk about the pre-oxygenation part, but what about apneic oxygenation? What is that and why does that matter? So it's exactly what it sounds like. It's passive oxygenation when the patient's apneic, so they're not breathing. So what we can do to achieve this is when we do that first intubation attempt, leave the nasal cannula on, right? The flow of oxygen down into the lungs, 25 liters a minute, that's a lot, down into the lungs passively can be enough to help bridge the extra few seconds to a minute that it might take to place and secure your ET tube. None of these methods are perfect, okay? Your really sick patients are still going to desaturate, but that's why you want to make sure somebody's monitoring the SpO2 during all of the attempts. And if the SpO2 starts to fall and falls rapidly, then we need to be able to stop and say, okay, we're going to go ahead and we're going to pause, we're going to come out, we're going to bag our patient, we're going to bag them back up into a safe range, and then we're going to do a second attempt, okay? So we talked about the respiratory side. That's how we optimize their respiratory side, prevent hopefully hypoxia from occurring. But what about the cardiovascular side? We want to be prepared for that as well. So we want to support them at the best we can and optimize them before we push any meds. So that means if they're hypotensive, consider giving fluids. If we give fluids and the fluids aren't enough to improve their pressure, then let's consider starting a pressor. Usually Levophed is the first choice that we go to, and that'll help to increase their blood pressure. We want to make sure they actually have a decent blood pressure before we go and push our induction meds. So what are those? So induction medications include an induction agent, such as etomidate or ketamine, and a paralytic, such as succinylcholine or rocuronium. Okay, so what are the differences and how do we do dosing and all of that? With our induction agents, or etomidate or our ketamine, we want to consider giving a half dose, okay? And why? The induction agent's going to cause hypotension in these patients, all right, even if it's ketamine. So there's this thing I hear a lot about ketamine where it causes a catecholamine surge. So it's going to increase your blood pressure. So you want to use ketamine on patients that are hypotensive because it's going to increase their blood pressure. But it only gives a catecholamine surge in patients that still have compensatory mechanisms. These patients don't. They've proven that by not being able to maintain their own blood pressure. So when you're sick patients, it's just as dangerous to push ketamine as it is to push any of the other induction agents. Okay, so don't be fooled by this idea that there's a catecholamine surge. Yes, there's a catecholamine surge in normal, healthy, otherwise patients. So you've got somebody that was in a motorcycle accident, and let's say that you're intubating them because they have an altered GCS, right? And you decide to give them ketamine. Yeah, you may see a spike in their blood pressure because there's nothing else physiologically wrong with them other than their potential for the TBI, concussion, bleed, whatever might be going on with their head. But in these really sick patients, they don't have this catecholamine response that you do in a healthy patient. So don't be fooled by that, okay? So consider half dosing this. And because their cardiac output is decreased, less induction agents required to gain the same amount of sedation. I mean, the patient already has a depressed mentation. So we don't need much more sedation to continue to keep them depressed, right? What about the paralytics though? We want to make sure we give a full dose of paralytics every time. And why? Because our cardiac output is decreased. So it's almost kind of the opposite. Induction, you don't need as much because they're decreased, cardiac output's decreased, so their mentation's already decreased, so we don't need a lot of sedation. Well, when our cardiac output is decreased with a paralytic, that means it's taking longer for the paralytic to actually circulate and get around where it needs to go, which is a lot more places than just the brain, which is where your sedation needs to go. So we want to make sure that we give a full dose to all patients that are receiving medications for intubation. There's no reason to ever half dose a paralytic. And then just keep in mind what the differences are between the paralytics. Succinylcholine, quick acting, it can cause fasciculation. So you're going to see that the shaking in patients, it can almost look like tremors or mild seizure activity if you've never seen it before, but it only lasts 3 to 5 minutes. Rocuronium, however, takes a little bit longer of an onset, doesn't have those fasciculations, but it can last, especially in your sicker patients, up to 40, 45 minutes. So you really want to keep in mind which paralytic is being given, because that's going to help to determine what your next steps of treatment are. Because we want to continue to support their blood pressure, right? So we're can keep doing fluid if fluid was working, or we can increase our Levophed as needed. And we also want to make sure that we keep their pain and sedation under control, all right? So again, you give rocuronium, your patient may be paralyzed for close to 45 minutes. Can they still feel pain? Yes. Can they be under sedated? Yes. Can you notice? Maybe not well, right? Their heart rate might be elevated because they're in pain, but you're not going to notice that because they're also septic and their heart rate was already elevated. Their blood pressure is already pretty low. Now you're starting to titrate your levo, so you may not see if they have a minor spike in their blood pressure from a lack of sedation. Just don't think that just because they're unresponsive, they don't have pain. These patients that get rocuronium can still be paralyzed for quite a bit of time. So make sure that you get from your provider pain medication and sedation. Just propofol is not enough. Just fentanyl is not enough in most of these patients, okay? If they have no GCS when they first arrive, then sure, you can argue that maintaining their blood pressure is more important at that point than starting a propofol infusion. And maybe you just do a small bolus of fentanyl or a small bolus of midazolam. But we really just need to make sure that we adequately treat their pain and their sedation. And what other medications might you encounter besides just those? So antibiotics, right? There are so many antibiotics that cover so many different things. And every time I use one, give one, anything, I tend to always have to look at some kind of a chart like this to make sure that it's correct. There's a very wide variety, as you can see here. So it does break down into major categories. Those that cover gram-positive and those that cover gram-negative. And then that further breaks down, you can see into cocci, anaerobes, coccobacilli, bacilli. So there's a lot of different categories. And the blood cultures that you drew when the patient arrived helps to pinpoint what bacteria it is so that you can select the appropriate antibiotic. There are also antifungal and antiviral medications, but again, they're less commonly seen. This is really kind of the chunk of your septic patients. And vasopressors, we touched on it a little bit with the Levophed earlier, but there are several different types of vasopressors that you could potentially see. So norepinephrine is the most commonly used one now. here we have a range of about 1 to 30 mics per minute. We mix 4 milligrams in a 250 ml bag, and we run it off of the pump, right? We never do pressors off pump. All pressors are always on pump. And norepi is a great one because it has a little bit of alpha and a little bit of beta 1. So what does that actually mean? So we're going to increase the contractility of the heart a little bit, increase the heart rate a little bit, as well as cause vasoconstriction with that alpha receptor. So we help a little on both sides. It's not just working the heart, it's not just working the vasculature, it's kind of working a little bit of both. Epinephrine is another option that can sometimes be the second medication that goes up on these patients. Again, range is about 1 to 30 mic per minute, so it's kind of helpful to remember. They're both fairly similar. And here we mix a milligram in a 250 bag, and again, we run it on the pump. Epinephrine hits on even more receptors. So not only your alpha, which is more your peripheral vasculature that helps to kind of clench down and tighten, but also your beta 1 and your beta 2 receptors. All right, so now we're working with the heart. It can work a little bit with the lungs, and it really just kind of helps to support the heart and the vasculature, again, like Levophed, but by causing a little bit more work with the heart, which in some ways is helping the body, it increases myocardial oxygen demand. So you just want to be a little bit more cautious with your patients that maybe have a history of cardiac disease or recent MIs. But if you're in a pickle and you're systolic 60 and you're maxed on your Levophed, you're going to do what you need to do to try to get that blood pressure up to a safe enough range that they can actually have perfusion to their major organs. For the things that you may see, dopamine used to be a lot more popular, a lot more common, not really used as often anymore. It does hit a variety of different receptors at different dose ranges. It does help to increase your blood pressure, but again, it's just not something that we see terribly often. So I'm not going to spend a ton of time with this one, and same with neosynephrine. So neosynephrine is just an alpha receptor agonist. So all it does is cause a squeeze in your blood vessels, your peripheral blood vessels, and that's it. It doesn't support your heart at all. It doesn't do anything else. It just squeezes and clamps it down. So it's really nice to use this in a patient with spinal shock, and we're going to have our shock lecture next month. So stay tuned for that. But it's helpful with that because all the body needs is a little tone. Or if somebody gets too much propofol and they become hypotensive, it gives them a little bit of a squeeze and helps with that. But otherwise, in a septic patient, really just giving you a number that looks better, but it's not actually helping the tissues get the perfusion that they need. So it's not something that we see terribly often in our septic patients. And then these are others I'm not going to touch on much. We don't use them here. Dobutamine is an inotrope. It's typically used more in the cardiovascular ICU, so we're not going to talk about that. It's not something that we use. And vasopressin is not a medication that we carry, but it's an antidiuretic hormone. And what's nice about this, it's frequently used with sepsis, and so we've talked about potentially having it here if we were to have the ability to, because what's great about it is it's a set it and forget it medication. So instead of having to titrate up and down based off of their blood pressure, you actually just turn it on at one rate and you leave it on until the patient stabilizes. And then once they stabilize, hours to days later, you just shut it off. The other nice thing that about vasopressin is that it works if your patient is extremely acidotic. So typically most of your pressors, they stop working as well once your pH drops below 7.1. And so you'll see that somebody that's really acidotic is going to be on really high pressor requirements. So their Levophed and their epinephrine can be at really high doses, say 30 mics each. But as that pH starts to improve, so we do really good vent settings, we blow off extra CO2, help to bring that pH up a little bit, not by giving tons of bicarb, because tons of bicarb does not fix that patient, okay? Tons of bicarb does not fix acidosis. That's totally other lecture, but I got to put it out there. Tons of bicarb does not fix anything. But we have really good vent management. We start to get our pH back into a normal range. You're going to see those pressor requirements start to come down pretty quickly. And that's why vasopressin is so nice. You have a really sick patient, really acidotic, throw vasopressin on and you can see a pretty nice bump in their blood pressure despite all the other medications not really seeming to make an impact. Again, I don't think we have it here necessarily because this is one that really works well more in the hours to days once they have their initial stabilization. And then the Surviving Sepsis campaign. This is a great resource. in order to kind of keep you up to date as what the goals are for sepsis management. So what they did is they put together this 1 hour bundle guide that helps to identify what's the most important things to do when a patient's been identified as a potential septic patient. So they meet 2 or more of the QSOFA criteria. Their assessment, their vitals, their labs, all of their things have come back and they're all piecing together saying, yes, we think that this is a septic patient. These are the goals for your first hour in that patient. So you might not have your labs back, right? It says here, measure a lactate level. Certainly not going to have that back instantaneously. Blood cultures, you're not going to have that back instantaneously either. But with your QSOFA, your vitals, your assessment, your sample history, that should be enough to get you to this step. And then the further information that you get from here, labs starting to come back, culture starting to come back, that's when you can say, yes, it's a definitive diagnosis. But this is kind of helping you to at least get the ball rolling and started on somebody that has the potential to get really sick. So it is currently being updated. And so go online for the most up-to-date. If in a couple weeks from now or 6 months from now, you're thinking, or you watch this video and you're like, oh, surviving sepsis, that's pretty cool. Go online, Google it, check it out. It may change slightly. I know one thing that they've been talking about changing is this 30 mL per kilo crystalloid, because for a lot of patients, it's too much, way too much fluid. Initially, we were thinking, yeah, this is great and it's really helping, but now we're seeing that it's way too much fluid for a patient. So always go online to read the most up-to-date literature, and whatever you do, just make sure you reassess after the intervention. So let's say you give fluid, reassess your patient. They have signs of fluid overload. They look like they could handle more fluid. Has it improved their blood pressure? Has it not improved their blood pressure? What's their heart rate looking right now? Because you would think if you gave some fluid, you might be able to bring that heart rate down a little bit. So always reassess after you do any intervention. Okay, so bringing it all together, in closing, sepsis can be really difficult to diagnose because it is so vague. No one thing is going to say this is definitely sepsis, right? So put all of the pieces together, all of those little lab abnormalities and, oh, that vital is a little off and that story is a little funny and they have a history of this. All of that comes together to help to create this diagnosis. When you have your patient, you've gone through some of the other differential diagnoses, right? Especially in the field, you're like, okay, it's not an MI, it's not a stroke, it's not TKA, it's not AFib with RVR, it's not all of these things, right? But I still don't know what's going on. They don't look that great. Their vitals aren't that great. Their story is this. I'm just not really quite sure. At least consider sepsis. Think of your QSOFA. Do I meet at least 2 of these criteria? Could I have an infectious source somewhere? And at least you've got some place to start, okay? As always, please reach out if you have any questions. If there's a lot of resources that are linked in throughout this presentation, so you can feel free to look at any of those. There's a lot of really great literature out there about sepsis, and it's a really detailed. So if you want to get really detailed in sepsis, you can do a lot of research and learn a lot about it. But hopefully this was a basic overview to help you feel a little bit more comfortable with this patient population, recognizing it, what some treatment modalities may be. And thank you so much for listening.